All right, so welcome everyone. Thank you for being here today for the first of our webinar series for World Breastfeeding Week. My name is Kara Kaikini and I use she, her pronouns, and I'm the board president of the Maine State Breastfeeding Coalition. And I'd first like to acknowledge that here in Freeport, I'm standing on Wabanaki and Abenaki territories. And if you're interested in learning more about the Indigenous territory you may be standing on, you can check out that website, native-land.ca. And the MSBC is a nonprofit that became established as a 501c3 back in 2017. We have a board of 11 incredible leaders, some of whom are here with us today. And hopefully they would introduce themselves as well. Our vision is that when every baby receives human milk, we will be a healthier Maine. And our mission is that we are a welcoming and broad network of people supporting families who value human milk and breastfeeding. And together we work to enhance the culture of breastfeeding around the state through professional networking, advocacy, and education. We have several committees and we're always looking for volunteers. So if you're interested, please fill out our volunteer form. I will put in all of these links into the chat box once I get through these slides and once Jacqui has started. So stay tuned if you want some easy links to click on. We also have a raffle right now for National Breastfeeding Month, the full month of August. And by attending today's webinar, you're automatically entered to win a $100 Visa gift card. And if you'd like to increase your chances of winning, you can purchase more raffle tickets through our Venmo account at Maine Breastfeeds if you have Venmo. You're also welcome to just make a general donation through PayPal as well. So if you have any questions about that, you can contact us and we're happy to help you through it. But we appreciate your support, your financial support as we continue to work on our strategic plan goals. We want to thank our supporters. We have annual patron partners, annual supporters, and annual advocates, and we also have a couple of event supporters as well. And they are all making this webinar series possible, in addition to helping us reach our mission and our strategic plan goals. So thank you to our incredible partners. And so we're excited to kick off World Breastfeeding Week with the first of 4 free educational opportunities. And you can register for those the same way you did for this one through our Eventbrite page. And many of you, I think, have registered for more than one. So thank you for that. We look forward to seeing you this week as well. So welcome to Jacqui. Jacqui is a registered dietitian nutritionist specializing in maternal and child nutrition. She's a certified lactation counselor, a mom of a 3-year-old, and the owner of Homegrown Nutrition located in Brunswick at Maine Mother and Company. In her practice, she guides parents and families through pregnancy and postpartum nutrition, lactation, and the introduction of solid foods to their babies. And she provides guidance with food allergies and peaceful mealtime strategies up through age 5. Jacqui practices nutrition counseling from a weight-inclusive paradigm, focusing on intuitive eating and body positivity to help break generational cycles of the diet mentality. Jacqui is passionate about helping families foster an environment at home where food is both joyful and nourishing. I'm so excited to have Jacqui here today. Thank you for being here and for sharing information with us about discovering and addressing potential allergens in mother's milk. I'm looking forward to learning more from you. So Jacqui, take it away.
All right. So I'm just going to share my screen. Okay. Can you guys see it? Okay. So thanks for the introduction, Kara. I really appreciate it. I'm really excited to be here today because this is something I'm really passionate about. And there's a lot of information out there that is not true and really confusing for parents. So let's just get into it. So a little bit about me, other than what she said, is I have a Master's of Science in Maternal and Child Nutrition from Case Western Reserve University. I also completed my dietetic internship there, which, is where I do a lot of supervised practice experience before I could sit for the board exam for me to become a registered dietitian. I also got my bachelor's in human nutrition from Orono in Maine, and I'm a certified lactation counselor, like she said. I really love working with parents of babies or children who have food allergies, because I can provide like a safe spot for them to fall for guidance on the process and next steps in care and management of potential food allergies, and helping them understand, is this a food allergy or not, which a lot of people can be worried about. And really helping them manage the food aspect of things, making sure that parents and baby have things to eat and they don't feel deprived, helping parents understand the nutrients that they may lose while avoiding certain foods and where else they can get those nutrients. And I provide guidance with reintroduction of foods for breastfeeding parent and infant or child, or both of them if it's appropriate. So objectives today, we're going to be reviewing the current myths related to the allergens in breast milk and why these myths can be harmful for breastfeeding success of parents with newborns. We're going to learn the different types of allergies that can present in infants, understand how proteins actually transfer in breast milk and what we know through the research about that, and then become familiar with when elimination diets are an appropriate next step, along with strategies for reintroduction of allergens after an elimination diet. So I'm just going to jump right into it, you guys, and talk about these myths. And some of this might surprise some of you. So bear with me as I explain all of this throughout the presentation. But working as a dietitian and a lactation counselor with the postpartum and infant population, there are certain things that I see quite often that really are upsetting. And one of those things is that most often the food that a breastfeeding parents are told to remove from their diets is dairy foods. It seems like this is like a quick go-to ask for many parents, whether it be from a pediatrician or like a family member or friend, and it is more complicated than you'd think, way more complicated. So for example, something that I might see is that a baby is spitting up more often, they seem fussy, they're gassy. The pediatrician recommends stopping dairy foods and tells the mom, don't eat that, but it will take 2 to 4 weeks for this potential allergen to leave your breast milk. So what this really means is that the mom then, or the parent, breastfeeding parent, has to supplement with a hypoallergenic formula during that time. And if she wants to continue breastfeeding, she has to pump exclusively at least 8 times per day, as you guys know, a lot of you, to maintain or build milk supply, while then dumping this colostrum or breast milk or donating it potentially, if the parent has the capacity to do that. So then this leads to problems with low supply, because right off the get-go, they're just using a pump when they necessarily might not have had to do that. The breastfeeding parents are then being even more frazzled and having to deal with cutting out a whole food group, which, like I said, is much harder than you'd think. And this gives the message that you cannot breastfeed a child with food allergies. So just for a quick understanding, and using dairy as an example, is that if the parent is already eating dairy and then they're just told to cut it out, it's not just like milk and butter and yogurt. It's also tons of different ingredients that they have to look at for every product that they're eating. And being a parent with a newborn is really, really tough to do. Even being a parent with a child, that's really, really tough to do. So it should only be done if there are evidence-based reasons for this to be needed. So in this little graphic, you can see that you can actually produce allergen-free breast milk in a day. So we're going to talk more about that. So what is the problem with this? I kind of already talked about it. It's easy to say, it's not easy to do. So we can really just, I think sometimes as a practitioner, when a parent is coming to me, or, just thinking of like the pediatrician or anybody who meets with parents, the lactation counselor, they come, and sometimes these parents, they're super frazzled. They're, feeling like, oh my God, why is my baby crying? My baby's gassy. They're spitting up. Is this vomit or is this spit up? And so it's an easy ask. You can just say, hey, stop eating dairy. But it's really, like I said, hard to do. And it can cause a lot of mental health issues as well, because really the parent, like this picture of this, wait, what is this bunny's name? Oh, now I can't remember. I should know that, but he is having a really hard time waking up to pump, really difficult. It's not based in evidence. We're going to talk a lot more about why that is true. And there's often a lack of interdisciplinary collaboration and teamwork. So I'm going to talk a little bit more about this later on, but as you guys may know, being a new parent, you have a lot of people that work as part of your healthcare team. So there's the lactation counselor, the pediatrician, maybe a dietitian, maybe there's like a nurse practitioner or a nurse at the pediatrician's office. There's, potentially an osteopathic doctor, a physical therapist, there might be a pediatric dentist, like all these people are working with the parent, and they sometimes, when whoever decides to tell them to try to remove a whole food group from their diet, it doesn't always get translated to the whole team. And there are certain members of the team who know more about this than other members. For example, the dietitian knows a lot about food that you would potentially be taking out of someone's diet. And so when that happens, they're often just told remove dairy, but they're not given any guidance. And then that can lead to them falling through the cracks. Maybe they're not removing all of that food, or maybe they never needed to in the first place. And they're still having all kinds of problems, but then it's making it harder for them to find foods to eat. Maybe they're a single parent that just doesn't have the capacity to be able to make sure that they're eating something that doesn't contain a food. So really working with the family as part of an interdisciplinary team to provide a whole patient care approach and letting them decide okay, this is maybe actually what's going on and what can I do to help it, or what can I do to figure it out? So when is the potential allergen out of breast milk? Research indicates that a single serving peaks in breast milk around 1 to 2 hours and steadily decreases thereafter. So these are general guidelines based on a surveying that we have in the research so far. There is an organization that I'm going to talk about later called Free to Feed that is run by a molecular biologist who had children with food allergies and experienced this runaround and then decided to make it her life's work to study. So she has a lot of really cool and exciting studies that are going on right now and things that she's figuring out. So her website is really worth checking out. But we know that proteins from a single serving typically clear within 8 hours. And this is the same for certain medications and flavonoids, alcohol. All of these things show the same or similar timeline for when those proteins or substances are out of the breast milk. And they're removed out of the breast milk either by removal of breast milk and also by cellular metabolism. So if we're looking at standard recommendations, we're really right now, it's to wait 24 hours for full clearance due to the possible differences in metabolism. But there's much more research needed in this topic. It really just hasn't been researched enough, similar to all breastfeeding and pregnancy things. Nobody wants to volunteer to be in a study where it's going to be testing what happens if you do a certain thing that could potentially affect their baby. So it's really tough to get this research, but people are doing it. And I think it's really important. So really in pediatric journals, the impact in infant symptoms, really, you can see a good decrease in their negative symptoms within 72 hours. So this is what the general recommendation is. When I work with my clients, I typically go with a 5-day rule because I feel like it's safe to see an impact in 5 days to field for differences. So everyone is different, as you guys may be able to imagine. When we're studying something, we can see a correlation or causation happen with a certain population of individuals, but there's always outliers. So I tend to do a 5-day rule. And then another typical recommendation among pediatricians and in pediatric journals is for moms to consider removing additional foods if the symptoms don't resolve after 2 weeks. So we'll talk a lot about that also. So the takeaway from this is that we don't have enough research to support, or we don't have any research actually to support the 2 to 4 weeks thing that everyone is being told. It takes 2 to 4 weeks for this milk protein to leave your breast milk, or this food protein to be out of your breast milk. And this is really impacting breastfeeding success of people, sometimes straight out of the hospital post-delivery. And I've seen it myself. I'm sure a lot of you guys have seen it if you work with this population. And this significantly impacts the quality of life of these families, the quality of life that they have and the enjoyment that they can experience during this really important time with their new family member that they just gave birth to. And during the first few years of life, it's just so important and super stressful. And I really think like why this misinformation exists and what part of the disconnect is that it can take time, possibly weeks, for the infant's gut to heal post-reaction. And so while the breast milk may be safe at that time, if the mom successfully removed the food that was really causing the issue, the baby can still be exhibiting symptoms because, and we'll talk about the different types of allergies, but there's sometimes a wound inside of the colon of the baby that if you're removing the food, there's still going to be some issues going on because the wound is healing. So it doesn't mean the breast milk is not good. It just means that the infant is healing. So different allergies that present in infants, and what are they? So allergies, just right off the bat, they are the infant's immune system or anybody's immune system reacting to a protein found in foods. And for infants, it's in foods that the breastfeeding parent is eating or that they're ingesting in their formula or something like that. So there are IgE mediated and non-IgE mediated allergies, which are also known as T-cell mediated allergies. And it's easiest to think of this as two groups, but it's definitely more nuanced than that, but this is just an easier way to explain it. So IgE mediated allergies are those that you would kind of expect, and I'm going to really go into detail on these in a second. And then the non-IgE cell mediated allergies are ones that we see most often in infants and breastfeeding infants under 6 months of age and under 12 months of age. And these, I'll explain all of them. So approximately 80% of food allergies occur before the first birthday. That doesn't mean that you can't get an allergy when you're like 90 years old. That can certainly happen, but 80% of them happen before the first birthday. In many non-IgE cases will actually resolve themselves within 9 to 12 months. And so that's why the general rule of thumb, but there definitely needs to be more research in this, is that you can reintroduce a food at least 6 months from the last reaction that they've had with that food, because they might not have a reaction to it anymore because their immune systems and their digestive systems are developing. So what is an IgE mediated allergy? So I wrote the word traditional here because this is what you would think of when you think of an allergy. They can be severe. They're very quick. It can happen within 15 minutes to 2 hours of ingesting a food. It can be life-threatening, and it often requires an EpiPen. I do like to point out that reactions of IgE-mediated reactions, if an infant is going to have one, it's not as likely to happen, and it is more mild when it happens the first time, and it would increase the more you introduce them to the food, but still very dangerous. So the things that you would look for are hives. That's a big one. Lip swelling, tongue swelling, coughing, throat tightness, wheezing, trouble breathing, rapid breathing, shortness of breath, nausea, repeated vomiting, which is often and plentiful. And one of the things I talk about parents with so much is like, what is vomit and what is spit up? So I won't get into all of those things in essence of time, but, and then weak pulse, anxiety, and agitation, and loss of consciousness. So these are all the potential things that can happen. And you may have noticed that trouble breathing, that airway shutting down, that's an anaphylactic response, which can happen as a result of an IgE mediated allergy, which is why they can often be life-threatening. So then there's food protein-induced allergic proctocolitis. So this one is the most common one that you'll see in an infant under age 1 and a breastfeeding infant. So don't mind these pictures of poop that I have over here, but this is really for you guys to see what blood in the stool looks like. And so at the top, it's more mild cases of seeing blood in the stool, but that's really what it looks like, flecks. And then other times, it's way more obvious. So it depends on the infant and the severity of the reaction. Another thing that causes that is really allergic proctocolitis is mucusy stool. So it kind of looks like, it makes me think of like the upside down in Stranger Things. It's like really mucusy and stringy. And so sometimes you just see that and not necessarily blood in the stool, but if they get their stool tested, they'll find flecks of blood in it. The stool can be green in this case sometimes. But green stool can also be normal. So this is why, you know, people like me and like pediatricians and other people who work with infants know about poop. And then excessive bowel movements is also another one, and fussiness in general, colicky babies, just babies being inconsolable. So this is a type of food allergy that affects the lower gastrointestinal tract. So this is like the colon, and particularly the second portion or the last portion of the colon. And that's why we see that bright red blood. Now, if you saw like black poop, black can mean old blood. So blood that's upper hot and higher in the digestive system, like in the small intestine or from the stomach. But this is what we typically see in infants, is it coming from the colon. Now, milk and soy are the known culprits of allergic proctocolitis. And this is the only non-IgE T-cell mediated allergic response that pediatric allergists across the board recommend to remove food for. So the other ones that I'm going to talk about after this, a lot of pediatric allergists don't recommend removing food for these. And so we'll talk about why it gets so tricky for parents when this is happening. But the reason why is because it can cause an allergy to remove the food. But this is the one of the only non-IgE T-cell mediated allergic responses that you recommend to remove the food for. And when I say cause an allergy, I mean an IgE mediated life-threatening allergy if you remove a food for the other ones. So that's that one. And like I said, milk and soy are the known culprits. Typically, we recommend removing milk for 1 to 2 weeks, just because, not because it takes that long to get out of the breast milk. You can still breastfeed during this time after 24 hours once you've stopped eating milk, but waiting 1 to 2 weeks to see if symptoms start to subside, because that's when baby's gut starts to heal and you might see them acting more happy and normal. And then if they're still not acting normal, and you're still seeing blood in the stool or something, then it's really important to continue to remove milk, but also remove soy in addition to this milk before moving on. And soy is just like milk. There's a ton of ingredients and things that they need to look for to make sure you remove soy, because it's in everything. Soy and milk have similar cellular structures. And so the immune system can't often tell them apart, which is why parents often have to remove both. And then the general rule of thumb is not to reintroduce this until 1 year, and you can safely do this at home. And this is one of the only ones that is known to be safe to reintroduce at home and like not in an allergist office. And 90% of babies grow out of allergic proctocolitis by age 1. So that's why you remove the milk, you remove the soy, the bleeding stops, then you can reintroduce at age 1. So this is food protein-induced enterocolitis syndrome, or FPIES. This is another one that I think is all over Instagram. And it's definitely really tough for parents. And so it's a type of food allergy that affects the GI tract, but not necessarily just the colon, but like also the small intestine and the stomach. And unlike an IgE mediated allergy that takes, anywhere from 15 minutes to 2 hours to see like that quick reaction. It might be a 2 to 3 hour delay or more onset before onset of any type of reaction, because the food needs to take time to get into the GI system for the body to start then attacking it. So signs and symptoms are repetitive vomiting, persistent diarrhea, dehydration, weight loss, lethargy, low blood pressure, and ashen appearance, and sometimes, failure to thrive if this goes undiagnosed. And this is something that not a lot of medical professionals know about. I mean, pediatricians certainly know about it, but like if you were to go to the emergency room and say, my child is vomiting, it's really hard to get people to take these parents seriously sometimes and realize that they need to like be triaged really quickly and taken through. So currently there's no blood or skin test specific to the diagnosis of FPIES. It's a diagnosis of exclusion made from gathering a careful clinical history. And this is why it's super important for parents to keep food logs and reaction logs with times on them. And this is something I help parents do, and I can give them like templates to do this with. And really the typical rule of thumb is to avoid the trigger food for a minimum of a year after the first reaction. But it's super important to not just remove whole food groups and remove everything. And this is something parents tend to want to do because they don't want their child to be repetitively vomiting every time they feed them. And this looks a lot like sepsis. So typically babies who have this will come in, and then they'll go to the ER, they'll have low blood pressure, they'll seem dehydrated, they get blood tests done. And the blood tests, the lab tests mimic infection, which makes the doctor think sepsis. And then they can go into sepsis-like shock. Now, this is worst case scenario. And many infants who are eventually diagnosed with FPIES are initially suspected to have a severe infection or sepsis. So it can mask itself like sepsis, but it's really FPIES. So it's just kind of crazy. And this is why it's really not important. It's important to not remove whole food groups, because studies show that when you do this, and I'll talk more about it, you can actually cause an allergy to happen. So yes, you want to remove the thing that's causing a severe reaction that could potentially lead to hospitalization and dehydration and failure to thrive. But you also need to figure out how many foods can this child tolerate, and try to give them as much as they can that they can tolerate to help their immune system develop, so that they don't go on to have a lot of different food allergies that are Ige mediated and very dangerous as they grow older. So then there's eosinophilic esophagitis. This affects the esophagus and the infant's ability to swallow. So in this picture, you can see a normal esophagus and what it looks like. Nice wide diameter. And then eosinophilic esophagitis, you can see inflammation makes that a little smaller, harder to swallow. And then if this keeps happening and isn't stopped, this can cause fibrosis, which is scar tissue that will develop. And then it could become really, really super small and need to be dilated medically. So signs and symptoms of this are nursing or food refusal, difficulty swallowing, frequent gagging, vomiting, difficulty sleeping, failure to thrive. So you can imagine that these symptoms that I keep saying for all of these can be tough to differentiate and tell the difference with an infant. So eosinophilic esophagitis is a chronic inflammatory disease, and it's driven by an immune response and characterized by the accumulation of immune cells, which is eosinophils, which is these purple things, or basophils or mast cells in the esophagus, and they may present at any age. So anybody could really get this. I see this in the hospital where I work. I work as a clinical dietitian at Midcoast Hospital, and also as a lactation counselor there as well as my private practice. So here is atopic dermatitis or eczema. So this is another common one that we see with babies. And I almost didn't even put this in the presentation because there's not a lot recommended for this when it comes to removing food, because one thing we do know is that if a food is completely removed for eczema, it can quite definitely cause an Ige mediated allergy to develop, which is one of those life-threatening allergies that will live with the child for the rest of their lives. So it's very it's a risky game to play, but this is dry, itchy, and inflamed rash on the skin. And it is known as I said there was IgE mediated and non-IgE mediated. This is definitely a non-IgE mediated allergic response, but it can sometimes be mixed because it is known to develop into something more if it's not handled correctly. So 35% of children with eczema go on to develop food allergies. Kids who have eczema worsening during a certain food protein intake will go on to develop a life-threatening food allergy if the food is removed because of eczema. So I'm just saying it again for the people in the back. It's really important. So management for this that's recommended is topical lotions, medicated ointments, just trying to manage it with that. Most of the time, eczema can be managed with topical lotions or medicated ointments. Long sleeve clothing, something to keep the infant from scratching themselves like this, wet wraps to keep it nice and cool and so that it feels a little bit better when it's really inflamed. Keep the infant's nails trimmed really well so they don't break it open. One thing that we do know through research is that if we say the parent is eating peanut butter or something and then doesn't wash their hands and goes and touches their infant where there's eczema, this can allow a food protein to have an entry point, which can then lead to them having an immune response that will end up developing into an IgE mediated allergy. So eczema is kind of weird, but I thought it was worth putting in here. So here's the major 8 allergens. So these are the foods that we look for here. So milk, egg, shellfish, fish, tree nuts, wheat, peanut, and soybean. And I do think that they may have, if they haven't already, or they're going to soon, add sesame to this list. But in the United States, this is what we recognize as the major 8. And this means that a certain threshold of the population of adults have IgE mediated responses to these certain foods. So those quick, fast allergenic responses that might require an EpiPen. And there's labeling requirements for these foods by law. They have to have contained statements about these foods on food labels. And these are different. These foods are different than the allergic responses that we see in infants that are often non-IgE mediated. So let's talk about what those are. So the top infant allergens for infants less than 6 months old, they're the top foods that have proteins that transfer readily from the mom's diet to their breast milk or the breastfeeding parent's diet to their breast milk that elicit a response in infants. And these are specifically based on published research from maternal reported infant food allergies, in addition to surveys that have been done by reputable organizations and nonprofits, combining their research to form this list of allergens. And then you can notice that there are 6 that overlap from the major 8 to this infant list. So that is cow milk or dairy products, soy, egg, wheat, tree nuts, and peanuts. And then the rest of them are not quite on the list. Rice and oats are the #1 anecdotal things. And when I say anecdotal, I mean, it's not necessarily evidence-based, but a lot of people report this that cause FPIEs. Just something to put out there. And so any child or human can react to any protein, but these are the top ones for infants via probability. And we can use this list, and I use this list to get the best probable removal for parents who are unsure what's going on. But this is why food journaling is so important for the breastfeeding parent, because there could be an outlier. There could be like broccoli or something like that, that is like really clear when you look at the food logs that they give, that isn't necessarily something that you would have noticed if you weren't doing a food log. And like I said, soy is structurally similar to milk protein, which is why milk is always the first line of defense to remove, and then we remove soy second. And I also like to note that other mammalian milk outside of human milk, like goat's milk, is structurally similar to cow's milk. And this is likely to elicit a response also, but not always. So I often see like on Instagram in the comment section, people just like writing, oh, we'll switch to goat's milk. Well, that's not recommended for many reasons, but that's one of them. So how do proteins transfer in milk? So let's talk about what is actually happening when dietary proteins transfer into human milk. So just what you're looking at right here. This is like the cell wall of the intestine, right? So what we would like to see in an ideal situation is that the cell wall is very tight and there's healthy, tight junctions, keeping the food proteins in the GI tract and out of the bloodstream, the whole intact proteins. But we often see this sometimes. So for example, the breastfeeding parent consumes eggs, and then so they swallow the eggs, they travel down the GI tract, and while they're traveling through, their cell wall, which in most cases will keep intact, whole, unbroken down proteins inside the GI tract, the gastrointestinal cell wall is essentially like the barrier between the gastric system and the circulatory system. So if you think of it like a brick and mortar wall, the tight junctions are like the mortar, if you will, to the brick and mortar wall. And so what we often see when an infant is having a reaction or like a potential reaction to breast milk is that the mom or the breastfeeding parent, when we're looking at them in studies, they have faulty tight junctions. So their tight junctions in their gut are open and they're allowing whole proteins inside. And so typically what's supposed to happen is whole proteins are meant to stay inside the GI tract until they are broken down enough to enter the circulatory system without issue. Once things enter the circulatory system, that then enters the breast tissue, and then it eventually gets into the breast milk, because breast milk is partially made from blood. And so proteins that remain whole and don't get broken down, they're meant to pass in our stool. But when we have faulty tight junctions like this, that is how those whole proteins get into the breast milk. So it's really tough because it will happen sometimes, it doesn't happen sometimes. It's really hard to tell when it's going to work well and when it isn't. And so, like I said, allergies are reactions to proteins that are present in certain foods. So what we, oh wait, let me just make sure I'm not in the wrong spot. Oh, so this whole process that I just explained is called gastrointestinal permeability. And what's important to know about this is that it's largely genetic. So while there are things that can be done to minimize this or potentially help it in the breastfeeding parent themselves, there is really little we can do to stop this completely in every individual, especially if it's something that you just figure out at the beginning of a breastfeeding journey, like right after they have their baby. It's unlikely that a mom will be able to have the capacity to heal her gut while newly postpartum. That's just, it's a lot of things to think about. There's a lot of factors that play into this. I mean, it could happen. It's just, I'm not saying it can't happen. It's just really a big ask, and something that I really hope to hit home with you guys, that moms should not feel guilty. We just see this a lot more in parents who have conditions like Crohn's disease, ulcerative colitis, celiac disease, IBS type symptoms, things like that. They tend to have more faulty tight junctions than ones who do not. And so there are certainly things that can be done to help prevent that, but it's not to say that it's going to change everything. And I wish that there was something that I could do to make and fix all of that, but there just isn't. So let's go on. I could also explain potential reasons why this happens in breastfeeding, in the breastfeeding parent. I mentioned like ulcerative colitis and celiac disease and stuff, but also things like stress or the maternal breastfeeding parent consuming foods that bother them gastrointestinally. Oftentimes parents are willing to remove any food for themselves if it means that it's going to help their baby, but they don't do it for themselves to help their symptoms, which is interesting. So you suspect an allergy in the infant, and now what do? So the biggest things that I always say is that, you know, I tell parents, like, if you see something that you're not sure about, try to take a picture of it right away if you can. You know, you see something that you think looks like a hive, or you see something like in the poop that you're not sure about, take pictures of it. If you're feeling like this is a more severe reaction, or you're really worried, obviously, yes, call your pediatrician. The things your pediatrician might do, and I'll talk more about this, is like a blood test, but a full panel blood test that they would look at like potential food allergens. This is for Ige mediated responses. a lot of false positives can occur. So I'll talk about that. But if that test becomes positive, then they'll refer to a pediatric allergist, which in Maine, this takes a long time to get into one. There's not a lot available. And then a stool test is another option if it's allergic proctocolitis, or if there's like a lot of mucusy stools, but they're not seeing any blood. Stool test. They look for flecks of blood in the stool. And if that's positive, they'll refer to a pediatric gastroenterologist. And then they can use a dietitian to help with elimination diets and reintroduction. So really, it's dependent on the infant reaction symptoms. How severe are they? How non-severe are they? And then it's really important to rule out breastfeeding or other potential issues unrelated to the maternal intake, like breastfeeding issues. So sometimes frothy green poop can be related to a baby having an imbalance of foremilk and hindmilk, as a lot of you guys probably know, which is a breastfeeding issue and not an allergy issue. And then sometimes like gassiness, spit up, colicky, babies, this is related to, you know, a breastfeeding issue, maybe tongue tie, lip tie, or a tight jaw causing improper latch, which is a breastfeeding issue and not an allergy. So sometimes if these things are corrected, those things get better. And it's not always just what the mom is eating. And that's, I think, what people want to jump to and really don't jump to it. Keeping that food and timing and symptom log is so important, just because then when they go to the doctor, they can have more of an idea and insight into what's going on to make their appointment more effective. And consider maternal health and breastfeeding goals. So super important. So sometimes the breastfeeding parent or their parents, they're just not hell bent on breastfeeding. It's not something that they are going to really beyond maybe the first couple of weeks be going crazy and turning their lives upside down to make happen. And so in this case, like they might have a mental health issue that caused them to have severe postpartum depression or anxiety or rage the last time they had their first baby. And now they're realizing like this isn't that big of a deal to them. So in these cases, there's so many more things I could say, but formula is a useful tool in these situations. And that's why hypoallergenic formula exists, because if there is a true allergy going on, there's really truly something happening that's going to make it so that this mom needs to, you know, be on an elimination diet to continue breastfeeding and stay eliminating certain food groups that might potentially be really difficult. And this is an option that they can have, but it's not required. So I think a lot of the times people feel like back to that myth that you cannot breastfeed a child with food allergies. I think a lot of the times like parents get this idea, and sometimes even pediatricians have this idea that they can't breastfeed anymore. Like it's out of the cards for them. And that's not true either. So as a practitioner, I try to work with my families to provide them care that is reasonable for them and their goals, in their family, in their situation. So just quickly, tests that we might go over, tests that might be done. So I mentioned briefly a blood test. So the blood tests for eosinophilic esophagitis, it will test for white blood cells, eosinophils, or a small biopsy from the esophagus. But most of the time, this one is used to blood test an infant for certain food allergies. Now, pediatric allergists, I've done a lot of training in this, and they recommend across the board trying to only look for the certain foods in that blood test that you're really finding suspect, which is why food logging is super important. So certain foods that are finding suspect, but not necessarily a full panel looking at all foods. And the reason why is because there's a significant risk in blood testing. Babies or children who have allergic diseases like food allergy, asthma, eczema, they're more likely to have false positives. Kids with siblings with food allergies are more likely to have false positives. And then the blood test can lead to unnecessarily avoiding foods that they don't need to avoid. So it's really important to only test for those IgE symptoms. And most allergists won't do these tests. They'll wait until 6 months, but if they do it before 6 months, they usually have to retest within 3 months to field for those false positive results. So just something to keep in mind there. The skin allergy test is pictured here. It's where they take like a small thin needle and have the allergy protein in it, inject it into the top layer of the skin and just wait in the office to see what happens and if there's a reaction. So these big ones down here are showing reactions, small ones not. So you can kind of see how that is, but this is really just for IgE mediated, those anaphylactic allergies. Same with the blood test, IgE and EoE, but not necessarily like FPIs, like I said. Stool culture, that's for allergic proctocolitis or FPI. And then a biopsy via an EGD, which is an endoscopy. That's for the EoE also, to look at the eosinophilic esophagitis. And then an oral food challenge that can be done in the allergist office for IgE, FPIs, or FPI. So now let's talk about maternal elimination diets. So I kind of went over each of those allergic responses that you might see. And I said the most common one that we would see is allergic proctocolitis, or that blood in the stool, which is most of the time caused by milk or soy, but sometimes it's not. Then there's FPIs. There's really severe vomiting in the child. Like I said, it's not recommended to just remove whole food groups because it can lead to an allergy. But it's another one of those important things to think about is we might not, we don't want to see a child consistently getting admitted to the ER being dehydrated because it's something that the mom could stop eating. So this is when these things are good, but reintroduction is also super important. So one at a time, this is removing one item at a time. So typically, like with allergic proctocolitis, I have my clients start with milk. This is really good for mild symptoms. I do want to point out, if I haven't already, allergic proctocolitis is super, it's not likely to cause, it's not life-threatening. It's really, really scary for parents to see, really scary. And I want to make sure that I recognize that. And at the same time, it's not life-threatening. So this is one of those good ones for that. So typically, like I said, starting with milk, several items together removed. This is like if there's a more severe reaction, like ton of blood in the stool, or like severe vomiting, and the child was admitted to the ER with sepsis like symptoms. This helps with faster results for more severe reactions, just because then that way the breast milk can become allergen free faster, stop eliciting a response in the infant. And then this is why it's super important to do reintroduction here with a professional, because then you can slowly reintroduce the foods that you removed and quickly be able to understand which one it was that was causing the issue. And then there's a total elimination diet. I just want to stress, this is not recommended, not recommended. And if you do it, professional guidance is recommended, but this is for very, very severe cases where the parent would eliminate all but 5 or so foods from their diet, the breastfeeding parent. And then that would help remove that very severe response, allow the baby a little bit of time to heal, and then slowly add things back under professional guidance. So let's talk about how reintroduction is done. I just want to state too why reintroduction is so important. And I keep saying it's important, but like why? Because there's research to indicate that early and often introduction of some proteins can help reduce the likelihood of a future IgE mediated allergy to those foods. So it's important that we are only cutting out things that we actually have to cut out, not just willy-nilly cutting everything out, not only for the breastfeeding parent's sake, but also for the baby's sake for future allergy development. And I'm not just talking about the major 8 or the major top infant allergies that I listed, but also just any food can become a potential allergen. Those are just the most common ones. So really important to not just be willy-nilly removing foods. And I think that because of the lack of support and interdisciplinary teamwork and that gaps I was talking about, parents falling through the cracks, this can often happen. And this is how a lot of people end up in my office, because they're like, I can't eat anything. I don't know what to eat. I've been removing everything. And they've had multiple different providers tell them to remove different foods. And then they're just left feeling like they can't eat enough food. And it's really disheartening. So this is a super important misstep. They're often told to remove foods, but not talked about why it's important to reintroduce those foods. And so there's different ways to reintroduce, direct and indirect. So the direct is directly to the child, which happens after 6 months when they've started solid foods. This allows for continued immune system development and complete healing post-reaction. And we recommend starting at the bottom of the ladder. So if you're looking at this ladder, this is for milk, cookie, and biscuit. So when something is baked, it's lower in the protein amount versus if you're just having straight up milk, the proteins are really whole. So the proteins are partially broken down in the baked items. So you want to start with a baked item, then move to something containing more milk that's not baked as long, something like cheese that has milk but not directly, yogurt, and then you've got the milk right at the top. So you can start at the bottom of the ladder when you're doing it directly to the infant, but indirect, this is when it's trialed through breast milk. So this is recommended to start at the top of the ladder every other day and then work there, or they can start at the bottom and work their way up slowly. But there's so much I could say about this, you guys. So I'm not going to get into it. So what is some support for parents? So like I said, and I can't say it enough, interdisciplinary teamwork. So find a team that works for you. And I know this is not always easy in the United States with our insurance barriers and things like that. But the lactation counselor may work with these kinds of families, the dietitian, a DO or an osteopathic doctor who does osteopathic manipulative therapy on infants with really tight jaws and neck muscles to help them have easier breastfeeding so that they're not ingesting air, which is causing problems that lead people to think they're having allergies. The pediatrician, an allergist, or a gastroenterologist. So websites I really like are the Free to Feed. So Free to Feed, if you Google it, it's would be the first thing that come up. This is with that molecular microbiologist that I talked about that's doing a lot of research in this subject. She provides a lot of information and good support for parents. And then the FPIES Foundation, they have an ER bag checklist for parents and a letter for the emergency room so that they can get moved up the triage list and get seen sooner. And then the American Partnership for Eosinophilic Disorders, they have questions that you can ask their doctor, support groups for allergies, not just eosinophilic. And the Asthma and Allergy Foundation of America has foods and ingredients containing certain foods, nutrients lost and how to get them, which is kind of like what I do. And then kids with food allergies, this provides allergy-free recipes for parents that they can choose which allergies are removed from the certain recipes and what to do if there is a reaction. And that's it. So I ran over a little bit. This is me with my son breastfeeding in an inner tube on the lake one summer. So feel free to ask me questions. Thank you guys for listening.
Thanks, Jacqui. That's a great picture. And we do have a few questions. That was incredible. There's so much information, and I appreciate it very much for as a lactation consultant, but also as a parent of children with food allergies. So we have one question I think you already addressed about whether or not their blood tests are being used to check the baby's gut. And so you did address blood tests to checking allergies, but I don't know if there's anything you want to say about checking the baby's gut.
Not necessarily. So when you have a young infant under a year of age, their gut is developing. So their gut microbiome and their whole digestive tract is not fully developed until they're at age 2. And so really at 6 months of age is when we see that we can start introducing solid foods, but they're not fully developed until age 2. So a lot can happen at that time, but there are things that, so I wouldn't recommend testing it. And the practitioners who I've worked with and pediatricians I've worked with also don't recommend it. Maybe there's someone out there who does, but that's the reason why, because so much can change as they're developing. But there are also certain things to consider, like, was the baby born via cesarean? Was there group B strep? Like, were they given antibiotics? Vaginally, like what happened. And so there are things you can do to kind of help support the gut microbiome of the infant, but really I wouldn't recommend looking at testing their gut, because I think it could lead to a lot of false things that make them go down rabbit holes.
Okay, and there's a follow-up question that just came through. Can you clarify the age of gut development, like the ages of how that develops? And that could probably be a whole other webinar.
Yes, that could be a
Um,
whole other webinar, but in a nutshell, I'll just say, so I do a workshop for parents on introduction to solid foods. And one thing that we know through research is that infants, after they're born, their gastrointestinal system is not quite ready to start solid food until we say around 6 months as the population recommendation, but really when they're sitting upright unassisted. So until they can sit upright unassisted, we know that they don't have the proper enzymes to digest certain things in solid foods, and they're really only able to tolerate breast milk or formula. And then after that, we have, like I said, there's always more research to be done in this topic, but right now what we can gather from the evidence is that around 2 years of age is when things are fully developed, which is when they have full use of pancreatic enzymes. They have, full, they have their own microbiome built up. That's not something that they're currently building based on the things that they're eating and stuff like that. So certainly nutrition plays an impact in this and helping develop a good gut microbiome. There's so much I could say, but yeah, that's really what the evidence shows for the ages.
Okay, great. And we have 3 questions left with 2 minutes left to go. So we'll do our best to keep this one. So is it possible to reverse EOE once that inflammation and scarring has started, and how to heal that?
Yes. So this is something that is out of my scope of practice. So this is something that I would recommend parents with this issue go see a pediatric gastroenterologist for this reason, because they'll know more about this than me. And at the same time, yes, there are certain things that can be done to help this. And infants, like they have such a high cell turnover. They're changing and building and growing all the time. So it's a little different than an adults who I see with eosinophilic esophagitis, where it's really much more of a permanent issue that they keep having to get corrected. But I will relay that to a gastroenterologist to fully answer that question.
Okay, excellent. And is there any way to remedy maternal gut health to reduce proteins getting into the bloodstream? How long does that take? And understanding it takes time and the need to be careful to not make moms feel guilty throughout that process. So any quick thoughts on that? And maybe while you are also saying that, could you share your contact information in the chat box for folks so they know how to refer people to you?
Yeah. So when we're thinking about repairing the gastrointestinal permeability, this is something that you read about online. People will talk about leaky gut. There's so much misinformation on this too, but I just want to say that that's kind of where that term comes from. And yeah, it's really just working. Dietitians do this a lot with people, but it's really working with the parent or the patient to help them figure out what trigger foods they do have, why that might be happening. Sometimes it's a hormonal reason. I work with women's health nutrition a lot. So there's a lot of things that have to go in tune with like the cycle of the maternal menstruation cycle and what happens there with hormones and what can happen then with certain foods that you're eating and what can cause issues. So there's certain things, there's so many different things that can be done to try to heal the gut. And the biggest main thing to start with is just avoiding those foods that they know are causing issue. But like you said, there's so much more I could say. So I'm just going to put my stuff in the chat box.
Okay, thank you. And we do have one last question about family history of food allergies. Is it true that that can increase the likelihood of allergies in the baby? And again, I'm sure there's a lot you could say about that, but if you have just a minute to share something about the history of food allergies in the family and the impact on the baby.
Yeah, so right now there's a lot of things that we don't know. As far as what we do know is that peanuts and egg of the major 8 are the only ones that we know of based on evidence that are genetic, that can get passed on in the family. Those ones we do know. But that doesn't mean that we don't know that doesn't mean that we don't know of other ones, but those are the ones that we definitely know, that if there's a first degree relative, like a parent or a sibling that has an IgE mediated allergy to like egg and peanuts, those infants are more likely to develop that allergy. But yeah, that's in a nutshell what I can say about it.
Okay. Thank
Is
you.
that all right, Kara?
Yeah, I know. Thank you. This has been so incredible. This information is wonderful. And I saw you put in at Homegrown Nutrition Me. That's your Instagram?
Yep, that's my handle. So from there, you can find my, I'm on Facebook and Instagram. You can find my website there. And I also have an email that I'm sticking in the chat box right now.
Perfect. Thank you. I know that there was another question that I don't think we'll have time for. So hopefully that person can contact you directly at jstevens@homegrownnutritionme.com. Thank you, Jacqui, so much. And thank you everyone for being here. We hope to see you in future webinars, and happy World Breastfeeding Week and National Breastfeeding Month. Have a good day.
Thank you. I really appreciate you guys sticking with me through this.